and butter for our practice, and we are all engaged in treating atrial flutter and atrial fibrillation much more than electrophysiologists, because these patients present usually to the family physician or internal medicine specialist or the cardiologist, and then the electrophysiologist get referral from us. So this is one of the reasons why we are so engaged and so fluttered with atrial flutter and atrial fibrillation. So what's atrial fibrillation? It's an ECG diagnosis. Although it has been described before the invention of the electrocardiogram by James McKenzie, by something called the polygraph. Those reading the ECC textbook of cardiology, there is 114 page for the atrial fibrillation, but there is a mistake at the beginning of the chapter, because they are calling it the polysomnograph. This is not the polysomnograph. Polysomnograph is a method of investigating obstructive sleep apnea, but probably it's a printing mistake. It's called the polygraph, and this was a recording of the jugular venous pulsations and the peripheral arterial pulsations, and it was first described by James McKenzie because of that. But it was not until Thomas Lewis came and recorded it by the electrocardiogram, and it remained since that time more than 100 years as an electrocardiographic diagnosis, in which the atrial activity is presented by oscillations of variable morphology, variable pattern, variable timing, and variable rate. And these represent the atrial activity at a rate of 300 to 600 beats per minute. And because of the variable concealed conduction in the AV node, you get irregularity of the pulse. You don't get concealed conduction. Concealed conduction this doesn't occur in atrial flutter, and therefore the control of the ventricular rate is much more difficult in atrial flutter than in atrial fibrillation, where we have a huge number of atrial activity invading the AV node and cannot exit of it irregularly. And this is the reason why we get a marked irregularity of the so-called irregularity of the arterial pulse. It's a most common sustained arrhythmia. Of course, it's not the most common arrhythmia. Extrasystoles are more common, but as a sustained arrhythmia, it's the most common. It's important because it's an important cause of stroke. The attributable risk, which is the risk of patients with atrial fibrillation over control, is 20%. It's associated with significant morbidity and mortality. Patients sometimes tolerate it very well. Other patients having the same time of atrial fibrillation with the same rate, but they cannot tolerate it at all, complaining of palpitation, malaise, syncope, exercise intolerance, and so forth. And it's known cause of dementia. Not only vascular dementia, but also enhances the occurrence of Alzheimer's dementia. And functional MRI, which is a sophisticated method of studying the brain function, not anatomy only, reveals that diminished blood flow to the brain is an important component of atrial fibrillation. It can also cause heart failure because of tachycardia-induced cardiomyopathy, and it increases the mortality 120 to 200% in compared with people without atrial fibrillation. Now, it's a disease of aging. This doesn't mean that it doesn't occur in young age. It does, but much less frequently. And when you encounter it in young age, you have to think of familial atrial fibrillation. You have to think of associated congenital anomalies, which are usually presented by significant cardiac pathology, like Epstein's anomaly, like tricuspid atresia, like pulmonary hypertension. But if you follow this, this is a study of almost 2 million individuals in Kaiser. Kaiser Permanent is an important insurance company for health in California, and it shows that as you move from 50 years of age to 85 years of age, there is consistent increase in the number of patients affected by atrial fibrillation. Above the age of 80, 10% of the population are having atrial fibrillation. And as you see, for men in red, for women in yellow, it affects also, this is applicable to both men and women. But observed that it's more common in men than in women. عشان الجرس اتضرب لأنه أنا بشتغل بالهوت سبوت. كده سامعيني؟
سامعين حضرتك.
لا. So if you look at it's consistently more common in men than in women. Some people misinterpret the Shatz-Bask score and think that it is a disease of females. The risk for stroke is more for females because most of the studies were including females at an older age. So there is a difference between the prevalence of disease gender-wise and the exposure to risk of stroke gender-wise. So the Shatz-Bask score, Bask is a 6 category, and it indicates that a female take 1 point, not available for males, as everybody knows that. But despite that, this is slightly more common in men than in women. So I just wanted to clarify this point because it's a point of confusion. Now, atrial fibrillation is never cured, except in very exceptional circumstances, like those who are taking specific forms of drugs, or those in the post-operative state, thyrotoxic atrial fibrillation. Apart from that, it's always a persistent disease and a progressive disease. So it's very important to prevent it right from the beginning. How you prevent it? You treat cardiovascular risk factors, including hypertension, diabetes, and dyslipidemia. These are probably not etiologic factors for atrial fibrillation. Most likely they are associations with atrial fibrillation. Smoking cessation, moderation of alcohol should not be a domestic problem here. Identify and treat hyperthyroidism. 15% of patients with hyperthyroidism we have atrial fibrillation, but among one, but still we have to look for hyperthyroidism because it requires a specific treatment. Proper pacemaker programming. We know that pacemaker, we have to avoid right ventricular pacing. Right ventricular pacing is associated with the development of right ventricular and left ventricular dysfunction, heart failure, elevated end diastolic pressure, atrial enlargement, and hence atrial fibrillation. There was a previous impression that treating patients with ACE inhibitor and ARBs and lower lipid agents can diminish the occurrence of atrial fibrillation, but actually this has not been supplemented by randomized trials. Whether sleep apnea is associated with higher onset of atrial fibrillation is still not settled, but still treating sleep apnea is going to improve the patient general-wise. One important factor is weight loss. And there is an Australian study that has been published several years ago. It is a study which included 150 patients with paroxysmal or persistent atrial fibrillation, body mass index overweight. And they half of them underwent a calorie restricted diet. They lost weight significantly, as you see on the left side of the screen. And with the associated significant loss of weight, there was a marked decrease in the atrial fibrillation symptom burden. So the atrial fibrillation risk decreased in these patients. There was a reduction in the left atrial size, left ventricular wall thickness. So weight loss is an important preventive measure in atrial fibrillation, not to be missed and not to be overlooked. Now everyone knows this classification. This is the only accepted classification for atrial fibrillation nowadays. We try to avoid vague terms like lone atrial fibrillation or chronic atrial fibrillation, but we know that atrial fibrillation can be a firstly detected phenomenon. It can persist within a week or less than a week. This is paroxysmal atrial fibrillation. It can continue for almost 1 complete year. This is persistent atrial fibrillation. If it persists for more than 1 year, it's called the long-standing persistent. And permanent is actually not a component of atrial fibrillation. It is a decision made by the patient and the doctor not to attempt rhythm control. Or it failed, rhythm control restoration was failed completely despite several attempts. Non-valvular atrial fibrillation, the guidelines that change once in a while. And now it includes patients with moderate to severe mitral stenosis and mechanical valves. So this was an important point because sometimes there is a confusion about giving the direct oral anticoagulants for patients with bioprosthesis, including TAB. Now it's accepted that this is a line of medication giving for bioprosthesis for patients with other valvular diseases. We don't know whether if we have rheumatic mitral regurg can be considered valvular or non-valvular because rheumatic mitral regurg was excluded from most of the studies. But the guide-wise recommendation is to consider moderate to severe anything mitral valve area below 2 square centimeters of rheumatic origin, as well as mechanical, not bioprosthetic valves, is considered as valvular atrial fibrillation, and we are banned from giving these patients Novac, NOAC, or DOAC, a better term than Novac. Now, this is a computer model for the pathogenesis of atrial fibrillation since the beginning of the second half of the 20th century by Mo et al. And this computer illustration shows the different wavelets that meander into the left atrium, maybe in the right atrium as well. Usually you have in the atrium, which is enlarged somewhere between 5 and 8 revolving waves. These waves annihilate or extinguish each other. They can reform and they can stimulate the formation of other waves. And these waves activate different fractions of the myocardium of the atrium and result in atrial fibrillation. Now, I stop here and get your attention to one important thing. To get the atrium accommodating to some between 5 and 8 wavelets, you need to have the wavelets of small size or the atrium of large size in order to accommodate this number of wavelets. If the atrium gets larger because of left ventricular dysfunction or vital mitral valve disease, and multiplied by the wave velocity. So if anything decreases the velocity or anything decreases the functional refractory period, it decreases the wavelength and allows the atrium to accommodate a larger number of the wavelets. So this explains why vagal stimulation by decreasing the velocity, as well as sympathetic stimulation by decreasing the functional refractory period, both can produce atrial fibrillation, although this might look counterintuitive. This is because vagal stimulation works by one mechanism in the formula, adrenergic stimulation works by another mechanism. And we know that there are two specific types of atrial fibrillation, one related to vagal stimulation, postprandial and during sleep, harder to control, maybe familial, or adrenergic stimulation evoked by exercise and relieved by rest. Now, if you look to the electrocardiogram at the bottom of the screen, you will find that there is this is a sinus bradycardia at the beginning here, and then there are multiple ectopic atrial beats, which results in the development of atrial fibrillation. How this can happen? This was the work of Hissagir in Bordeaux, France, several years ago, and I will come to it in the next slide. But many of the changes that occur in the atrium during atrial fibrillation is a progressive fibrosis or the anatomical remodeling which occur in these conditions. If you compare the degree of fibrosis in some normal sinus rhythm, it's 5%. Paroxysmal atrial fibrillation, it jumps almost to 3-fold, and then persistent atrial fibrillation, it jumps to 7-fold the amount of fibrosis. So as I said before, atrial fibrillation is a progressive disease. It can change from paroxysmal less than a week to persistent less than a year to long-standing persistent that can be cardioverted but more than a year. During the initial stages of atrial fibrillation, it depends on the process of triggering it by action potential development in the pulmonary veins essentially. It can also arise from other structures like the superior vena cava, inferior vena cava, coronary sinus ligament of Marshall, which is a remnant of the left superior vena cava. You can get paroxysmal supraventricular tachycardia or atrial fibrillation that excites, or atrial flutter that excites the occurrence of atrial fibrillation, something we call tachycardia-induced atrial fibrillation or tachycardia-induced tachycardia. But as time passes by, This gets substantiated by an alteration of the substrate of atrial fibrillation through electrical remodeling by changes in the function of the sodium, potassium, and calcium channel, neurohormonal changes, the development of atrial fibrosis that I just pointed to a while ago, and the progressive atrial enlargement. Remember that atrial enlargement can occur because of the underlying cause like mitral valve disease, or can occur because of atrial fibrillation itself can produce progressive atrial enlargement without another responsible factor. So what is the aim of treating atrial fibrillation? The aim is not to eradicate atrial fibrillation because that is impossible. So right from the beginning, the patient should understand that we are trying to attenuate or decrease the burden of atrial fibrillation and not to eliminate it totally. This occurs only in very few exceptional circumstances. So the aim is to reduce the risk of thromboembolism, preserve ventricular function, and prevent the development of tachycardiomyopathy, minimize but not eliminate the symptoms because this is impossible, and improve the quality of life. So if you get recurrence of atrial fibrillation after starting an effective treatment, the recurrence that is associated with less symptoms and less hemodynamic disturbance, then this doesn't mean failure of treatment. It means that we are improving the burden, decreasing the risk of atrial fibrillation, and that's the ultimatum in treating this condition. So knowing that, we will move to the first question. An 80-year-old woman with prior stroke, diabetes, readmitted for the third time with permanent atrial fibrillation and rapid ventricular response. She's in heart failure, creatinine 2.9. So is having chronic kidney disease, creatinine clearance way down 13 milliliter per minute. She undergoes a pacemaker implantation and AV nodal ablation. And she high is going to be about 5. So the question is, what if the following is regarding the subsequent therapy is correct? Should she be discharged with the pacer at a lower rate of 60 beats per minute, or takes dabigatran 70 milligrams twice daily and which can be substituted for warfarin, or takes aspirin and clopidogrel instead of warfarin, or she should continue oral anticoagulation, or the left atrial appendage occlusion device should be implanted? The correct answer is D. She should continue on warfarin. Why not the others? The first is she can be discharged with a lower pacemaker rate at a rate of 60 per minute. This is wrong. After ablating the sinus node, you get sudden change from rapid ventricular rate during atrial fibrillation to a slow junctional rate, and this will lead to dispersion of the QT interval, and as a result of that, development of torsades de pointes and ventricular fibrillation. So after AV node ablation, which is a technically simple procedure, in contrast to SA node ablation that we alluded to previously in inappropriate sinus tachycardia last time, AV node ablation is a straightforward, easy to do, and successful procedure. You should keep the pacemaker somewhere between 80, 90, and 100 for several months, and then decrease it gradually in order to avoid the occurrence of torsades de pointes. Dabigatran cannot be given to this patient. She is in heart failure and she is in renal failure, 2 contraindications. Aspirin and clopidogrel cannot substitute warfarin. I will show you the pivotal trial which got the antiplatelets away from our way in treating atrial fibrillation. And this patient is able to take anticoagulants long term. There is no problem with that. So it's not a candidate for left atrial appendage occlusion device like the Riat, Watchman, or Emulet, or Amplatzer, or whatever. So there are several methods by which you can identify left atrial thrombosis. Left atrial thrombosis, 90% of the time, is in the left atrial appendix, transesophageal echo at the mid-esophageal level, and in this angle, we will show it with the trabeculations. If you are not sure and you are thinking of stasis, you measure the velocity at the mouth of the left atrial appendix. Normal should be 1 meter per second. Anything below 0.7 meter per second is indicative of slow flow into the left atrial appendix and the impending left atrial appendix thrombi. MRI and CT can show signal void because the thrombus is a non-revascularized structure, and we know that without anticoagulation, the risk of having thromboembolism is somewhere between 2 and 5% per year. And embolism can go to the brain, producing horrible infarctions, sometimes hemorrhagic in the presence of the anticoagulation, or can go to the intestine, leg, and the coronary arteries. The reason why thrombosis occur here is multifactorial, including stasis, endothelial dysfunction, and hypercoagulability, because we are dealing with a chronic inflammatory condition. Because of that, several risk scores have been identified to classify patients according to the risk of thromboembolism. Remember that this is a general risk factors. Atrial fibrillation is not included among them, but atrial fibrillation, of course, is the platform on which it is. Previously, we were using the SHADS score, but the SHADS score suffered that zero SHADS score is not associated with zero risk of thromboembolism. And because of that, it was associated with 1.9 or 2% thromboembolism, which is equivalent to the risk of giving anticoagulants. So that was confusing and was replaced by the SHADS VASC score. Everybody knows about that and the scoring points for it, so I'm not going to read them. But if you look at zero SHADS VASC score, is associated with zero adjusted anticoagulation risk. And only when it exceeds 2, that the risk of anticoagulants will become less than the risk of thromboembolism. And that's the reason why in males, 2 or more, and in females, 3 or more is indication for anticoagulation. Anything is less than 1, which is 0, is not indication, and 1 is an indication from the story, anticoagulation or nothing. That's the thing. One important point which I find it somewhat confusing for many people is that we calculate one scoring point for females, provided that they have other risk factors. So if you have a 35-year-old female without other risk factors, then it is scored 0. But if you have an elderly female and associated with other risk factors, then you calculate it 1. So there are some caveats in interpreting this. There is another scoring that came after the SHADS VASC score called the ATRIA score. It's a confusing score, and when it was matched against the SHADS VASC score, the SHADS VASC won, and therefore forget about the atrial classification or scoring system. It was dividing the age groups into 4 and a complicated interaction between the different risk factors and age, the age groups. So anticoagulation for atrial fibrillation, this is the previous guidelines of 2014, now changed, 0, nothing, 1 anticoagulation or nothing, no role for aspirin as is seen in this study and this slide, and 2 or more in males or 3 or more in females oral anticoagulation. Now, what about 1, which is confusing? You lean to give anticoagulants if there are other factors that influence your decision. Left ventricular hypertrophy, left atrial enlargement, bleeding risk, you avoid anticoagulants. But we anticoagulate certain diseases without looking for the SHADS VASC score, including hypertrophic cardiomyopathy and rheumatic mitral stenosis. There is no place for calculating the SHADS VASC score in these 2 circumstances. One important point is that do not hold anticoagulation for minor bleeding like epistaxis or the risk of having an older patient falling to the ground. The risk is small and doesn't justify the risk of stopping or holding anticoagulation. Now, this is a Cox diagram which shows the importance of giving patients warfarin, and as you see, several studies where the outcome of them is that there is a decrease of 65% relative risk reduction if you give warfarin to patients with atrial fibrillation, whether we are talking about paroxysmal or persistent atrial or permanent atrial fibrillation. One important caveat in interpreting this studies is that warfarin was given and was in the therapeutic range again 65% of the time. If you don't have warfarin given to the patient and he is in the therapeutic range 2 to 3 INR 65% of the time, then you are not prone to get a 65% reduction in the incidence of strokes. So this is one of the limitations of giving warfarin. And this is illustrated in this slide from many years ago, an important anticoagulation clinic. One patient was followed for 5 years, and yet you see between these two lines is the therapeutic range, but the INR is all over the place. If it is present, if it's not in the therapeutic range 65% of the time, then you cannot get the 65% reduction of the incidence of thromboembolism. Big problem for warfarin. If you give an overdose, then the patient is at risk of hemorrhage with the INR above 3. If the patient is undercoagulated, he is in the risk of thromboembolism. And as a result of that, you get a small number of patients actually are taking warfarin because of the fluctuating effect of warfarin and its interaction with drugs and even food. So when we had the anticoagulants several years ago, antiplatelets several years ago, we thought that combining antiplatelet drugs might obviate the disadvantages of warfarin. And that was studied in a pivotal trial, the ACTIV-W trial. And as you see here, the incidence of stroke is definitely much less with warfarin than with the combination of antiplatelet drugs. And this ended forever the role of antiplatelet drugs, except in preferred therapy in acute coronary syndromes. Apart from that, shouldn't be given for patients with atrial fibrillation. And the introduction of the so-called novel anticoagulant several years ago, now almost 10 years ago, so it's no longer novel, you might call it the direct antagonizing the factor 2, dabigatran, or factor 10, rivaroxaban, epixaban, and indoxaban, and the matrixaban. Matrixaban so far is not approved for atrial fibrillation. It is approved for the prophylaxis against TVT and treatment of pulmonary embolism. But as you see, the direct-acting anticoagulants are working downstairs in the cascade system, in contradistinction to warfarin, which works up here, factors 2, 7, 9, and 10. So the direct anticoagulants have established their places through a series of trials. Most of you are quite familiar with it, so I will go rapidly with it. Dabigatran was studied in the Realignment trial in 2 doses, a small dose 110 milligram BID or 150 milligram BID against warfarin. And the FDA approved the larger dose because it has a better anti-thrombotic effect and an equivalent bleeding effect. So it was approved 10 years ago. Well, another study, which is the Realignment studies, showed that dabigatran cannot be given in patients with mechanical valves. It increases the thromboembolic risk and also increases the bleeding risk. So this was a definitive trial not to order not only dabigatran, but all the DOACs or NOACs for patients with mechanical valve, and this holds true so far. Rivaroxaban was studied in a pivotal trial, which is a Rocket AF trial, and it was the warfarin against the rivaroxaban in a huge number of patients. And the outcome is that the efficacy of roxaban was not inferior to the efficacy of warfarin, less intracranial hemorrhage, most gastrointestinal hemorrhage. The important point to remember about rivaroxaban, it has a poor absorption, so it should be given with the main meal. So abroad they give it with dinner. We give it here with the noon meal. The main meal should be given in order to enhance it. We see many patients are not taking it, and since we don't have a laboratory test, we don't know whether they are anticoagulated or not anticoagulated. All of these patients, they are having a half-life of 12 hours. That's relatively short to warfarin. So the patient misses one dose, he is at risk of thromboembolism. Apixaban or Eliquis has been studied in a pivotal trial, the Aristotle trial, a huge number, and again, It was superior to warfarin with less stroke and embolism, lower major bleeding, lower intracranial hemorrhage, no difference in gastrointestinal bleeding, and lower mortality. Now, the opinion about Eliquis has changed. There was contraindication in patients with renal dysfunction, underweight, and old age. Now, the only contraindication is higher serum creatinine or rising serum creatinine. And more recently, in the update, it is one of two anticoagulants. Warfarin is the other one, which is indicated in patients with end-stage renal failure and patients on dialysis. So patients on dialysis and patients in end-stage renal failure, as of the last recommendations of the American Heart, American College focused update of 2019, is to give either apixaban, Eliquis, in a reduced dose of 2.5 milligram twice daily. Now, endoxaban is a strange drug with a unique pharmacokinetics in the whole pharmacology, and it was studied in the Engage AF 15848 in a large number of patients, but the important point is to know that it's renally excreted like the others, so you have to watch the GFR, and the important unique point is that it's not recommended if the GFR is too low, below 15 milliliter per minute, or too high, because an increased glomerular filtration rate is prone to wash it out through the kidney and therefore diminish its activity. Remember, in the initial stage of diabetic nephropathy, you get an increase in the GFR, so you have to be watchful of that. If the GFR is above 895 supernormal, then this is a contraindication to it. This is a cheat sheet or a table which is comparing the different anticoagulants. I will just point to the important points here. The half-life is almost equal, about 12 hours for all of them. Whether you give them once or twice, it doesn't depend on the half-life. It depends but here you have to be cautious, except with apixaban, which, as I alluded to just now, can be given down to a very low glomerular filtration rate, or even in patients who are on dialysis. There is an important drug interaction with the NOAC. Now, this is because these are relatively recent, although they are 10 years old now. Most of them was introduced around 2010, 2011. But you have to know that they are excreted by the P-glycoprotein, and they are metabolized by the C3A4. So anything which induces, that accentuates the effect of these two enzyme systems is prone to decrease the drug level. So it's important to remember that the P-glycoprotein is induced by rifampin, and the C3A4 is induced by the anticonvulsants like phenytoin and carbamazepine, and as well as by rifampin. And both of them are inhibited by ketoconazole and other antiretroviral drugs used in treatment of HIV. So this is an important point. Those sitting in the examination should be able to revise it the night before the examination. What is inducing the P-glycoprotein, what's inhibiting it, what's inducing the C3A4, and what's inhibiting it. So the specific issues about how to reverse the anticoagulation for warfarin: simple, vitamin K given orally in small doses, fresh frozen plasma, and 4-factor prothrombin complex concentrate. The problem comes with the new anticoagulants, dabigatran. We have a specific antidote for it, which is idarucizumab. This is not available in Egypt, of course, but still you can use prothrombin complex concentrates in case you get life-threatening bleeding. Since these drugs have short half-life, just waiting for their effect to dissipate in the occasion of non-life-threatening bleeding will be acceptable. Rivaroxaban, apixaban, and endoxaban, they have a specific antidote, which is a special molecule similar to factor A10A, which is andexanet. Also is not available in Egypt, but prothrombin complex concentrate can be a substitute. For patients undergoing surgery, you can stop the drug somewhere between 1 and 5 days, and the patient will be okay and ready for surgery. It's important to know that we usually do not bridge. We don't stop the drug and substitute it for warfarin by heparin, except under very exceptional circumstances. This was one of the important points emphasized in the latest guidelines and the focus update last year, not to try to stop the drug, make sure that the patient is taking these drugs, don't bridge except in very exceptional circumstances. One of them is mechanical valve, and the other one is a history of thromboembolism, particularly if it is within the last 6 months. This shows the importance of finding and looking for patients with renal dysfunction in order to avoid the use of these two WACs. And as I said, whenever you come down before a glomerular filtration rate of 50 milliliters per minute, you have to be cautious. Most of them, they should not be recommended when you come below 15 creatinine clearance or estimated glomerular filter rate, with the exception of apixaban. Obviously, this slide is outdated, and the new recommendation is that you can use Eliquis or apixaban down to glomerular filtration rate very low, and even in patients on dialysis. So it became the second drug to an anticoagulant in addition to warfarin for use in these terminal conditions. If you have a patient who is a candidate for anticoagulation and at the same time is not tolerant for prolonged anticoagulation, then you might think of the left atrial occlusion devices. These left atrial occlusion devices, we have one of them approved by the FDA, which is the Watchman device. This Watchman device is composed of a nitinol mesh, which is covered by tetrafluoropolyethylene, and this enhances the coagulation. As you know, it's introduced transceptally and is located in the appendage. It's a cumbersome procedure because we have a variety of shapes and what is called the chicken wing or the window sock. These are window sock اللي هي عبارة عن الكم اللي بيبقى متعلق في المطارات ده عشان يوري اتجاه الريح. It's a prolonged structure and long enough to be a situs for thrombosis because of stasis and endothelial dysfunction. We have a variety of at least a dozen of these occlusion devices, including the ambulatory plug occlusion, including the amulet occlusing device, and all of them are not approved by the FDA so far, but they are in action in Europe. But the indication for these patients, for this occluded device, they are patients at increased risk because of the high SHADS score, VASC score, but at the same time, they are not suitable for anticoagulants on long-term basis. On short-term basis, they should be fit for anticoagulation because usually these patients, whatever device you are implanting, you have to keep them for 45 days on anticoagulation, then for 6 months on dual antiplatelet therapy, and then you continue on aspirin. So this is one way of avoiding long-term anticoagulation, and if you compare it with warfarin, they are less efficient in preventing thromboembolic phenomena than warfarin, but obviously they are more perfect in obviating the tendency of bleeding, particularly intracranial hemorrhage. So the second question, a 56-year-old otherwise healthy woman returns to your office 4 weeks after direct cardioversion for persistent atrial fibrillation. She feels well for 2 weeks after the cardioversion, but now she's again getting another episode of atrial fibrillation, troubling her by dyspnea, palpitation on minimal exertion. The ECG approves the presence of atrial fibrillation with a controlled ventricular rate, and the medications include metoprolol, digoxin, and warfarin. So the question, what is the best treatment option now? Start flecainide, which is 1C drug, and repeat cardioversion, continue the present medical therapy with rate control and forget about reverting heart to sinus rhythm, refer heart to catheter ablation, do surgical maze operation, or repeat cardioversion with intravenous amlodipine. The correct answer is A, start flecainide and repeat cardioversion. Now, why not the others? continue the present. The guideline says that if you fail cardioversion, then you give one antiarrhythmic drug of class 1 or class 3, and under these circumstances, you can repeat the cardioversion with more success. This is the guideline. So here, this patient, there is no evidence from the stem of the question that she is having a structural heart disease. So she is fit for patient for a 1C drug, propafenone or flecainide. B is continue the present medical treatment with rate control and anticoagulation. This patient is very, very prone to cardioversion, and she's troubled by the symptoms. So better to keep her in sinus rhythm. Refer her for catheter ablation. You can do that, but this is 2B. You have to try antiarrhythmic drug, at least one drug first before implementing catheter ablation. This is a class 1 recommendation. You can also do ablation without previous antiarrhythmic drugs, but this is a class 2B recommendation. Refer to surgical maze operation. Obviously, this is a very invasive procedure. You should not resort to it except after 2 ablations fail and all antiarrhythmic drugs fail. Usually, there is a concept for people working in this field is that if one antiarrhythmic drug fails to revert sinus rhythm, then the possibility of other antiarrhythmic drugs to fail is big. And that's why the guidelines says if one antiarrhythmic drug fails, then you can resort to another electrical procedure. Repeat cardioversion and use intravenous amutolide. Intravenous amutolide is a class 3 recommendation. Is a class 3 antiarrhythmic drug and is prone to produce torsatic ones and is used in patients with a structural heart disease. Here, there is no evidence of structural heart disease. So this is a very similar study that my generation and probably those coming after me closely remember it. The AFFIRM trial. The AFFIRM trial is a landmark study in and was comparing 2 strategies in treatment of atrial fibrillation. It was not comparing sinus rhythm against atrial fibrillation because that is not a question. We obviously like our patients to be in sinus rhythm. That avoids the complications of atrial fibrillation. So there is no point in asking the question, is sinus rhythm better or not than atrial fibrillation? It was comparing a strategy of treatment that leads to sinus rhythm with a strategy of treatment that keeps atrial fibrillation but controls the rate. And the result was very astonishing to the medical community, particularly the cardiac community at that time, since it showed that the patients who are getting rhythm control are actually getting more mortality and even more stroke than patients who are getting rate control. Now, although the difference was not statistically significant, but it was a strong signal in favor of rate control rather than rhythm control. Now, the reason why the rhythm control was having more mortality is because of the toxicity of the antiarrhythmic drugs, which was used to revert to sinus rhythm, and why these patients were having more strokes because the investigators stopped the anticoagulation in patients who went into sinus rhythm. So stopping anticoagulation and giving antiarrhythmic drugs increased the mortality and increased the incidence of stroke rate. So that was not understood at the beginning of this study, but we learned a lot from this study. We learned that using antiarrhythmic drugs solely to revert sinus rhythm is a bad thing. We know that even if the patient reverts to sinus rhythm, then he should continue on anticoagulation according to the Shards-Vasc score. Otherwise, you will lose the value of resorting to sinus rhythm. So that's the AFFIRM trial, and this is the understanding of how it was conducted and was misinterpreted at the beginning, and then the value of it later on. Rate control, obviously, we use beta blockers as the first line. We use non-dihydropyridine calcium antagonist, provided that the patient is not having left ventricular dysfunction. Digoxin always comes late, but it can be added to either of these conditions. Target of therapy is to minimize symptoms, prevent the occurrence of tachycardic cardiomyopathy, and then keep the heart rate at a lower rate possible. So an acceptable rate is actually 70 beats per minute for patients at rest, 100 beats per minute for patients on minimal exercise, 130 beats per minute or around these figures in patients with maximum exercise. Now again, these recommendations obviates the conclusion of another trial called the RACE-2 trial. The RACE-2 trial was comparing a lenient control defined by the investigators as a heart rate of 110 beats per minute at rest against a strict control defined by the investigators as 75 beats per minute. But if you look to the details of the study, the patients who had been randomized to lenient trial actually have a heart rate of 86 per minute. So as a result of that, the results of the RACE-2 trial was not implemented in the guidelines. The guidelines refrain from keeping the patient at a high heart rate in order to obviate the occurrence of tachycardia-induced cardiomyopathy. So I repeat, usually we like our patients to be around 70 at rest, 100 on minimal activity, 130 on maximum activity. You will find different figures in different sources of the literature, but that's the most accepted and reasonable figures to apply. Now, if you fail to control the rate, then you ablate and pace. And as I told you, ablating the AV node is a very simple procedure, takes a small energy and takes a small amount of time, very successful. But the problem is that the patient, number one, will remain on anticoagulation because the atrial fibrillation will be going into the atrium. And at the same time, the patient will be lifelong dependent on ventricular pacing. And here comes the problem. If you pace the right ventricle, you end up with cardiomyopathy. So although the procedure reduces symptoms, improves the quality of life, and is well accepted when you fail with drug therapy, sometimes you need biventricular pacing in order to prevent the occurrence of left ventricular dysfunction, particularly if you have an ejection fraction at baseline below 40. Whether you can do biventricular pacing as a standby in patients with normal ejection fraction, that's a debatable point, but is a respected point that should be considered on individual pacing. And as I told you, after ablation, you should keep the heart rate, the ventricular rate, on the higher side of normal, 80 to 90, for several months, and then gradually decrease it down to 70 or 60 in order to avoid the dispersion of the QT interval and the occurrence of torsated ones that can degenerate into ventricular fibrillation. انتوا سامعيني ولا لا؟ الو؟
يا دكتور محمد سامعين حضرتك.
سامعين؟ طيب بس انا بتكلم
دكتور محمد سامعينك كويس.
بتكلم نفسي.
لا سامعينك كويس يا دكتور محمد.
طيب شكرا جزيلا. Now, rhythm control, the drugs which are available, unfortunately not in Egypt, but these 4 drugs at the top of the slide those are available intravenously in the United States. Ibutylide, fetolide, flecainide, propafenone. Remember, for those who are interested in reading the ESC guidelines for the fetolide, because of its restriction and the mandate of giving it in the hospital for 3 days to avoid the occurrence of torsated ones, have been completely eliminated from the guidelines of the ESC for atrial fibrillation and replaced by another class 3 drug called the vernaculant, and I will come to this soon. If these 4 drugs fail, then you can give amiodarone as a chemical agent for cardioversion. Obviously, cardioversion by electrical means is more effective, and you can use biphasic waveform. This slide is not very accurate. You can use 200 for the biphasic. You can use 360 for the monophasic. Very few biphasic equipments can come up to 360. They should be synchronized, of course. You can repeat the procedure after a butylide injection. Unfortunately, it's not available to us in Egypt. But the important point is that the patient should be anticoagulated for 3 weeks before and 1 month after cardioversion, as everyone knows that. The alternative is to do transesophageal echo and then make sure that there is no thrombi in the left atrial appendix, but still the patient should be anticoagulated 1 month or 4 weeks post-cardioversion. But the most important point, what about after that month? You calculate the Shabs-Vaska score. If it is more than 2 in males, if it is more than 3 in females, or less than that, if there is other risk factors that I just pointed out a while ago, then you should continue anticoagulation. If the patient is taking the DOACs, then verify that the patient took the last dose. Because if you omit the last dose, particularly in the twice daily drugs, then the patient is not protected. So this is important. So this is after reverting to sinus rhythm, you need to maintain the patient in sinus rhythm. And this is the recommendations for the American Heart, American College. There is a similar recommendation with minor deviations from the European Society of Cardiology. And if you have no structural heart disease by echo or any other means, then you can use anything. These are arranged alphabetically, so don't consider. You can use dofetilide, you can use dronedarone, you can use flecainide, propafenone, or sotalol. They fail, you go to amiodarone or catheter ablation. Now, as I told you, dofetilide has been erased by the European Society. They are replacing it by vernaculan. Vernaculan is a class 3 antiarrhythmic drug which works on a sodium and potassium channel peculiar to the atrium. It's called the I means current, K means potassium, UR ultra rapid. The IKUR current is absolutely placed in the atrium. So the main result, it is not pro-arrhythmic because it doesn't act on the ventricle and produce serious arrhythmia. So it obviates and never accompanied by Torsades de Pointes. I don't know why it's not approved in the United States so far, but this is the main difference between the only difference between the antiarrhythmic drugs chosen for maintenance of sinus rhythm between the American and the European. Obviously, admitting the patients to give him a drug for 3 days and in a monitored bed is going to be expensive and is unsubstantiated by logic. If the patient has significant left ventricular hypertrophy defined by the guidelines as more than 1.5 centimeter, dronedarone or amiodarone or catheter ablation. For patients with heart failure, only 2 drugs are approved for maintenance of sinus rhythm, amiodarone and dofetilide. If they fail, you go to catheter ablation. Patients with coronary artery disease, same drugs with added sotalol, amiodarone, and catheter ablation if they fail. So this is the approved guidelines. Postoperative atrial fibrillation is our bread and butter. We see every now and then the cardiac surgeons are tired with us because of this. It occurs in almost 50% in patients postoperative, particularly those undergoing valve surgery. And it is the result of the hypoxia, electrolyte disturbance, adrenergic stimulation, inflammatory state of the postoperative. The good news is that because of this trial, the Cardiothoracic Surgical Trial Network published in 2016, whether you adopt rate control or rhythm control, the outcome is that most of the patients will get rid of the atrial fibrillation by 60 days. By 60 days, 85% of the patients, by any means, they are getting rid of the atrial fibrillation and they can leave the hospital, even 30 days before the end of the study. So under these circumstances, it's left at the discretion of the treating physician, whether to rate control or rhythm control. What we do is that we evaluate the degree of symptomatology of the patient. If he doesn't tolerate the irregularity of the procedure, we cardiovert him, keep him on beta blockers or amiodarone. To prevent it, there are a variety of methods because the traditional method is to load the patient prone to postoperative atrial fibrillation undergoing valve surgery or CABG by amiodarone 3 weeks before that. You can use beta blocker. Some people use beta colchicine. Some people use dexamethasone. Some people use the 3 omega amino acids. All of these are anti-inflammatory drugs, but the traditional teaching and guidelines recommend amiodarone loading and beta blockers. Don't stop beta blockers before operation, even if the anesthesiologist insists on that. You should be engaging with a scientific discussion to convince him with that. Now, in a special situation in thyrotoxicosis, previously we said that patients should be anticoagulated irrespective of what. Now the guidelines recommends that you should go with the Shatz-Vasc score after giving the patient beta blockers. Obviously, we don't try to revert the patient to sinus rhythm before getting rid and controlling the thyrotoxicosis. In pregnancy, atrial fibrillation is quite rare. If you have atrial fibrillation, then you have to consider underlying cardiac disease. But still, you can treat it with beta blocker for rate control. You can cardiovert if the patient does not tolerate the arrhythmia. You anticoagulate according to the general rules of pregnancy by heparin or low molecular weight heparin for the first trimester and the last 15 days, and in between small dose of water. Keep away from the DOAC because they have not been studied sufficiently in pregnancy, so we don't know whether how far they are teratogenic. Probably they are, and so should be avoided. Hypertrophic cardiomyopathy, don't apply Shatz-Vasc score. They should be anticoagulated irrespective of what. Disopyramide is not available in the world market and obviously is not available in Egypt, but the guideline is keeping it because it has an effect on obstructive cardiomyopathy. As you know, amiodarone is probably the drug of choice, but still you can use alternatives, including sotalol, bupitalide, and amiodarone. Asthma and chronic obstructive lung disease, be cautious with beta blockers. As you know, don't try to play with these things because you say and test them for reactivity or something like that. Sometimes asthma occurs in a severe form just by giving the beta blocker, particularly in patients with chronic lung disease. Question 3. You have been caring for a 68-year-old woman with hypertension, peripheral vascular disease, with recurrent symptomatic paroxysmal atrial fibrillation for several years. Sequential trials of flecainide sotalol have been ineffective in controlling symptoms, and you are thinking about referring the heart for ablation. The states concerning ablation of the fibrillation is true. The procedure most likely to improve the symptoms and quality of life. Electrical isolation of the pulmonary veins is not important for the procedure efficacy. Major complication rate is less than 1%. Overall complication rates are lower with cryoballoon ablation than with radiofrequency ablation. Anticoagulants must be stopped after 2 months if there is no atrial fibrillation on Holter monitor. The correct answer is A. The procedure was most likely to improve symptoms and quality of life. Now let's consider the others. Isolation of the pulmonary veins is not important. Of course, it is the key step in stopping atrial fibrillation is to isolate the pulmonary veins by a variety of methods that we are coming to, and probably Ahmed al-Damati is going to detail on that when he comes, if he comes. Major complication rate is less than 1%. This is wrong. The literature is 2 to 5%. Obviously, everyone is looking for reduction of the major complication rate, but we are not still there. It's 2 to 5% in all the publications. The world publications, obviously, it can be higher than that. Overall complication rate are lower with the cryoballoon ablation. No, the same complication rates is present for cryoablation and radiofrequency ablation, and I will come to that very soon. Anticoagulation is stopped after 2 months. If there is no atrial fibrillation, we should continue anticoagulation based on the Shatz-Vasc score. This was the big mistake that we learned from the AFFIRM trial, not to stop anticoagulation if the patient is a candidate for anticoagulation. Now, the gold standard that is a horrible operation is the surgical maze operation by Cox Maze several years ago. And the aim was to cut and sew 12 lines of incisions in the atrium, separating the right atrial appendix and left atrial appendix, encircling the pulmonary veins and cutting the connection between superior and inferior vena cava and the pulmonary veins and the mitral ring. As you see, it's a horrible operation. It's not a standalone operation except very exceptionally. It's usually done in association with our open heart surgery. And we know that there are at least 5 versions now of the Cox Maze operation. although it's still considered the guidelines by which we compare all the others, it's associated with a significant decrease in the occurrence of atrial fibrillation, 75 to 95 long-term persistence of sinus rhythm. Unfortunately, it's associated with sinus node dysfunction and pacemaker implantation in 10 to 15% of the patients, and it leads to a 5 to 10% decrease in the left atrial emptying fraction for transport function. So although it's a landmark surgical study, it's too drastic to be applicable. And as time went by, we came to a landmark study by Hessagir in Bordeaux, France, 22 years ago, which invented for the first time a balloon which goes into the pulmonary veins. I don't know how he got the idea, but in just a small number of patients with paroxysmal atrial fibrillation and PVC could prove that the atrial fibrillation is triggered by impulses coming from the pulmonary veins. And particularly in his paper, the majority of these patients were coming from the upper left pulmonary vein and then the upper right pulmonary vein. What is specific about the pulmonary vein is this. We have muscle sleeves encircling the origin of the pulmonary veins and going into the inside of the pulmonary veins from the left atrium. So the pulmonary veins are stable structures moving with respiration alone, but the heart is moving with the ventricular contraction and atrial contraction. So here is the hinge point. This hinge point is mechanically activated and probably is the reason for the induction of triggered activity, particularly late after depolarization, which is the inciting factor for the occurrence of the arrhythmia. Now this invades the atrium and undergo several modifications because the activation of ganglionic plexi on the posterior wall of the atrium, as well as what we call CAFE or fractionated atrial electrogram, which is areas of fibrosis which fractionate the impulse and produces multiple wavelets that colloid, extinguish, and reform, or can create a rotor protein rapidly, so it fibrillates. So the role of the pulmonary veins and the autonomic innervation near the pulmonary veins is actually playing a vital role, and that is the driving force before the invention of pulmonary vein isolation, which can be done actually around the pulmonary veins itself, or a wide area of circumferential ablation, which is called WACA, wide area circumferential ablation. And this wide area isolates the pulmonary veins and it prevents the conduction of the atrial impulses of the pulmonary vein impulses into the left atrium. And you have to prove after the ablation, whether you are applying radiofrequency ablation or cryoablation, you have to prove bidirectional block. If you pace the pulmonary vein, you cannot activate the atrium if it is in sinus rhythm. And if you pace the atrium, you cannot activate the pulmonary vein. You wait 30 minutes after that, give adenosine in order to shorten the refractory period inside and excite the occurrence of atrial fibrillation and make sure that atrial fibrillation doesn't recur. So we isolate the vein, create bidirectional block, give adenosine, wait half an hour, and make sure. Now this is a discussion which happened several times in the conference when Amir Abdul Wahab was there. Amir, I found him, and there are gaps between this radio frequency foci. ولما كنت اقول له يا امير طب ليه الجابس دي هي يعني كان يقول لي ما تصدقش اللي في الكتاب ده يعني مكياج. This is not right. People after a while discovered if you have a gap between these points, if you have, I hope the pointer is clear. If you have a gap between these points, then the impulse will escape from the pulmonary veins to this gap. And either the atrial fibrillation will recur or you end up with atrial flutter. And this is a left atrial flutter, which is difficult to ablate. It's not isthmus-dependent atrial flutter. So I hope this will be more clarified by the talk of Dr. Ahmed Damati. That's the reason I wanted to keep him with us here to say a different or similar opinion. I hope he will fulfill his promise and come. Now, after this, the introduction of these methods, there was an enormous enthusiasm for it, supported by this study. One of them is the thermocool study, which compared symptomatic atrial fibrillation ablation versus drug therapy. And as you see, that the curves are widely separated in favor of ablation. And even not only symptomatic atrial fibrillation, but symptomatic and silent atrial fibrillation, also there is a large gap. Now, the common method of using radio frequency here, it's used the ablation with the open irrigated radio frequency current. So this study was done with the existing technology, which is adopted now. And as you see, the arrhythmia is less, and the quality of life is more, because symptoms is better, because the symptoms are less. Now, because the procedure is time consuming, takes time to make point-by-point application, make sure that there is no gap in between. And sometimes you connect the pulmonary vein ablation lines, so you connect them with the mitral annulus, you connect them across the roof of the left atrium, and you ablate the posterior wall of the left atrium in order to get rid of the ganglionic plexi and the cafe. And because this is a time-consuming, effort-consuming procedure, cryoballoon ablation was invented, and under these circumstances, the balloon just slipped into the mouth of the pulmonary vein. You put it down with nitrous oxide down to a 40 to 50, minus 40 to 50 degrees centigrade, and under these circumstances, you ablate this area and prevent the occurrence of transmission of ectopic pulmonary foci activity down to the atrium. Now, the main problem with this is that you cannot make extra lines of ablation. You cannot ablate the posterior wall of the left atrium. You cannot ablate the roof of the left atrium. You cannot connect the inferior pulmonary veins with the mitral annulus. But despite that, in the Stop AF trial, cryoablation was successful in ablating atrial fibrillation 70%, various in contrast to only 1/10 of this figure for drug ablation. The other problem is that when it's rare with the radio frequency ablation, and it's relatively common in with the cryoballoon ablation. But the whole all in all, the complication rate of cryoablation is similar to radio frequency ablation. And then we come to the most recent and the landmark trial that has been awaited for quite a long time, the Cabana trial by Douglas Becker of the Mayo Clinic. Now, this Cabana trial occupied the mind of people working in the field for several years, and the results, you can judge it when I finish with it. Now, it's a study which included 2,200 patients, and they were randomized simply into drug therapy according to the discretion of the investigator, rate control or rhythm control according to the judgment of the investigator, versus ablation using the modern technology of radio frequency or cryoablations and the present day technology for this. And these were followed for 5 years. And you can imagine that the people were waiting for the results, is ablation is better or not. Now, the final outcome after 5 years is that there was no difference. Absolutely no difference. But the problem is here. If you look here, you will find that patients who were assigned to drug therapy, 27% of them crossed to the ablation arm. And if the patients were assigned to ablation therapy changed in their mind in 9% of the patients and moved towards the drug therapy, and they refused the ablation. So the analysis of the trial, if it is done by the traditional bias-free method, which is intention to treat analysis, no difference. No difference in the primary endpoint of death, disabling stroke, serious bleeding, or cardiac arrest. But if you only look for patients who are actually received the treatment, what we call an on-treatment analysis, then there is a difference. If there is an on-treatment analysis, which is not the official method of comparing in the randomized trials. Why? Because it introduces tremendous bias. So if you do the analysis by on treatment analysis, not by intention of treatment analysis, then there is a 33% reduction, relative risk reduction of the endpoint of death, disablement to serious bleeding or cardiac arrest. So that's the Cabana trial. It's published last year, and obviously that this kind of large trials, they have at least 20 publications, many of them to come. So keep tuned and find out what is going to come out of the Cabana trial. Actually, I don't think there is any center of the world that decreased the occurrence, the procedure of ablating atrial fibrillation after publication of the Cabana trial. On the contrary, many centers of electrophysiology have at least 2/3 of the volume of their work ablating for atrial fibrillation. So what's the present situation for catheter ablation for atrial fibrillation? These are the key points. It's reasonable for symptomatic atrial fibrillation refractory to one or more antiarrhythmic drug. By one or more, we means one or more of class 1 or class 3. And one, because there is an impression, right or wrong, by the electrophysiologist and the cardiologist alike, that if one fails, then others are going to fail. Electrical isolation of the pulmonary veins is a key component, particularly when it's an extensive isolation, making sure that you have to strike a balance between completeness of the isolation and the electrocautery, and changing the left atrium into a fibrous bag with poor emptying fraction. So the extensive ablation is going to include autonomic ablation, complex electrocardiogram or cafe ablation, or ablation for non-pulmonary vein triggers, SVC, IVC, coronary sinus, vein of Marshall, mitral vein, tricuspid vein, and so forth. Success rate is miraculous, 60 to 8% in patients with atrial fibrillation, but you have to know this. It's better in paroxysmal than in persistent, in patients with short duration, less than 1 year, than in patients with long-standing atrial fibrillation. In patients with a small left atrium, defined as less than 5 centimeters, in younger patients, defined that less than 75% patients who are having cardiomyopathy as a result of the atrial fibrillation, they are obviously good candidates. But you don't know whether tachycardiomyopathy is a really tachycardiomyopathy or a cardiomyopathy complicated by atrial fibrillation. No way to know that. It's a retrospective diagnosis, and I think Professor Muhammad Abdulghani was alluding to that in a good question last time. If a patient has a complete occlusion proximal LAD, then and the cardiomyopathy, do open the LAD. We have an answer, but I have a different approach. I discussed it with Ahmed Al-Gindi, and I think it's not a single answer. It's a complicated answer, but it was an excellent question, no doubt about it. So the guidelines say that class 1 indication for catheter ablation, symptomatic paroxysmal atrial fibrillation that is refractory to or intolerant to class 1 or class 3 antiarrhythmic drugs, at least one. If the patient is having persistent atrial fibrillation and is still symptomatic and defying antiarrhythmic drugs, it's class 2A, but still class 2A patients symptomatic paroxysmal atrial fibrillation, and then you don't give the patient antiarrhythmic trial. So still can be accepted as a class 2A concept and to try ablation as the first procedure. Actually, what most people are doing is that if the patient is having terrible symptoms and long-standing atrial fibrillation, we go to ablation without trying antiarrhythmic drugs. If it is recent and the patient is not on antiarrhythmic drugs, we try antiarrhythmic drugs. One, if it fails, we go to ablation. Ablation is very important, and ablation is a successful procedure in the hands of experienced persons in experienced places. But the important point is that the patient don't understand what's behind it. So they should understand the procedure. Even if they refuse, what I do for my patients is that I postpone the discussion for the next time, but I still discuss it for the second time and third time and the fourth time. Every time, if the patient is resisting drug therapy, and he cannot accept atrial fibrillation, so he's not a candidate for rate control, then I keep pushing in the way of ablation, and I think we have good ablation. Ahmed Damati in the department now, we are proud of him, and he's doing a great job. Class 3 indication is the patients who cannot be anticoagulated, or the patient the sole intention of ablation is to obviate the need for anticoagulation. The reason is that even if the patient goes back to sinus rhythm, we apply the Scherz-Vasquez rule and we anticoagulate the patient according to that. The risk factors for atrial fibrillation with thromboembolism is not related to atrial fibrillation in the first place. It's related to the comorbidity that has been abbreviated ably by the Scherz-Vasquez score, as we alluded to. So ablation risks, it's not free of risk, but the risk somewhere between 2 and 5% in good hands, maybe higher in people under training. Pulmonary vein stenosis, 1%, presenting by cuff hemoptysis, and they should be evaluated by CT and MRI and treated by dilatation and stenting. Stroke in 0.5 to 1%. Cardiac tamponade, you should be very aware of the proper anticoagulation of these patients and flushing of the sheath. And if you work on the left side of the heart, control of the anticoagulation. Right front nerve paralysis, very rare with radio frequency, 1 to 3% prescribe balloon ablation, presents by a negative sniff test, a dyspnea, and the chest X-ray sufficient to show the elevated copula of the diaphragm, right copula. And the big problem, which is very rare, is the left atrial esophageal fistula. This can present with fever, sepsis, difficulty with swallowing, delirium, and the stroke. The important point is that it might not be present while the patient is in the hospital. It appears usually within the first months after the procedure. It's very rare because most centers now, we have a thermistor in the esophagus, and while ablating the left atrial wall and the pulmonary vein entrance, they measure the temperature in the esophagus and make sure that it's not get heated, so the possibility of sloughing the atria. The important is that these patients are a contraindication for esophageal intubation. It's diagnosed by CT and MRI. As we said a while ago, the risk is not 1%, it's 2 to 5%. One slide about the surgical ablation of atrial fibrillation. Obviously, after the introduction of radiofrequency cryoablation, this is losing adherent, but sometimes if ablation fails repeatedly, and if a drug therapy fails repeatedly, then these patients can be candidate for surgical ablation. It's frequently done nowadays by thoracoscopy and as a semi-invasive procedure, not open heart surgery. And if you look carefully here, this is a clamp, and this clamp is closing on the pulmonary veins and make the ablation from outside the heart. Same applies to the other pulmonary veins. And sometimes epicardially, you can connect the mitral annulus with the ablated pulmonary veins, and in this way you can make a complete interruption of whatever possible available here. So it allows the isolation of the pulmonary veins, and it allows the other ablation lines to be implemented. It can also allow semi-invasively left atrial occlusion and maybe right atrial occlusion. The procedure is usually done as a part of other cardiac surgery like mitral valve surgery, but a class 2B as a standalone procedure under exceptional circumstances. So I will move now from atrial fibrillation to a few slides about atrial flutter. So atrial flutter actually is another condition which we don't see very frequently. So it's about 1/5 the frequency of atrial fibrillation. Although in infancy and childhood, atrial flutter is more common than atrial fibrillation. So its recognition of atrial flutter is important because the line of treatment is important. Here, the atrial activity is a macro re-entry circuit, usually located in the right atrium, less frequently elsewhere in the atrium. and the atrial rate is somewhere between 250 and 350, and usually you get an AV conduction with an even number, 2 to 1, 4 to 1, 6 to 1, 8 to 1. Very rare you get an odd number. If the conduction is 1 to 1, this means that we have an excellent fastly conducting AV node, and under these circumstances the ventricular rate will be about 300. Every time you see ventricular rate is a fraction of 300, like 150, and less importantly 75, think of atrial flutter. If the conduction is way below that, 6 to 1, think of binodal conduction. You have problem with the sinus node, and therefore there is atrial flutter, and you have problem with the AV node, and this has an impact on choosing the line of therapy. The epidemiology and the evaluation is similar to atrial fibrillation with different prevalence in adults and in childhood. Anticoagulation, although thromboembolism is less frequent with atrial flutter, but is not much less frequent, and therefore the application of the VASC score still holds with atrial flutter the same as in atrial fibrillation. The major distinctions between atrial fibrillation is atrial flutter is in the mechanism and in the role of catheter ablation, which is class 1 recommendation in patients with chronic atrial flutter, and the class 2 recommendation in patients with atrial fibrillation in absence of previous antiarrhythmic drugs. So here we have a macro re-entry circuit, and the re-entry as a mechanism of arrhythmia requires a simple thing. Don't confuse yourself by too many requirements. You need a loop with a slow zone, and this is a loop and a slow zone. Why a slow zone? A slow zone in order for the head of the activating, I hope you see the pointer. The head of the activating wave doesn't hit the tail of the previous wave. If it hits the tail of the previous wave, it extinguishes the circuit. It stops. So you have to have a slow zone. And this slow zone is a key factor in treating the re-entry. And if you ablate the slow zone, because without the slow zone, there is the wide slow zone. If you ablate the slow zone, then you extinguish the circuit. Now, as you see, it's a macro re-entry circuit located totally into the right atrium. You go from the tricuspid valve, you go up the septum, you go counterclockwise down the free wall at the crista terminalis, and you end up with a slow zone. The left atrium is activated passively through above here the interatrial bundle, and here through the fossa ovalis, and lower down through the coronary sinus. You can get the loop as a large loop, or you can get shortcuts. Now, the important thing of treatment is ablation, a line of ablation here, or multiple spots of ablation in the slow zone. Make sure that there is bidirectional block. If you activate to the right side of the ablation, it cannot go to the left side. It has to rotate all the way and come to the other side of the ablation line from this. So this is very easy to find by electrophysiology. And if you activate from the on the other side, the free wall, it cannot jump near the coronary sinus orifice. It has to rotate. If this is called an isthmus-dependent atrial flutter. It has to go into the isthmus. The isthmus is the narrow area between the inferior vena cava and the tricuspid valve. Now, this isthmus-dependent atrial flutter, if it goes counterclockwise, it's typical atrial flutter. If it goes clockwise, it is atypical isthmus-dependent atrial flutter. So atrial flutter is divided into an isthmus-dependent and a non-isthmus-dependent. I will come to the non-isthmus-dependent in the next slide or the one after it. But the isthmus-dependent can be typical or atypical depending on whether we are talking about clockwise or counterclockwise. There is something called the type 1C atrial flutter. In patients with atrial fibrillation, if you give them flecainide or propafenone, they organize their atrial fibrillation and they change it into atrial flutter. Now, this atrial flutter can conduct one-to-one conduction across the AV node and thereby increase the ventricular rate. So if you start with atrial fibrillation with a ventricular rate with 100, you change with atrial flutter with a ventricular rate of 300 or 150, and this puts the patient at the mercy of occurrence of ventricular fibrillation. That's why we have to combine flecainide and propafenone with beta blockers to prevent the occurrence of atrial flutter with one-to-one conduction. Moreover, this is class 1C, which has a profound effect on the conduction system, and therefore they produce aberration. So if you change atrial fibrillation into atrial flutter, and one atrial flutter will conduct one-to-one, it will conduct with wide QRS complex. Why? Because of impaired conduction produced by the 1C drug. So the final outlook will be ventricular tachycardia simulating situation. It's actually atrial flutter conducting one-to-one with aberration. So if you give flecainide and propafenone without beta blocking, although everyone knows that propafenone has a beta blocking effect, but minor, then you end up with a very serious arrhythmia that looks like ventricular fibrillation. And if you treat it as ventricular fibrillation, it's not going to stop. This is atrial flutter, specific form of atrial flutter related to 1C antiarrhythmic drugs. That's why it's called 1C atrial flutter. Now, this is the cavotricuspid isthmus, which is the isthmus located between the inferior vena cava and the tricuspid valve. And as you see here, Ahmad al-Damati is putting his catheter and he's pulling it back here to create a line of block. If you stimulate and the coronary sinus, you can't come to this point, except when you go all the way around the circle to the other side. And if you stimulate here, you cannot go to the coronary sinus catheter located in the coronary sinus except by going in the other direction. So it's not the end result, the end point of treating atrial isthmus-dependent atrial flutter is not just getting away from the atrial flutter or getting it abolished, but creating an addition, a bidirectional irreversible block. Despite that, you can get two problems: a 3 to 5% recurrence of atrial flutter, and sometimes you get a huge number of late occurrence of atrial fibrillation that can lead to congestive heart failure and left ventricular dysfunction. So it's important to know that we are dealing with two cousins, atrial flutter and atrial fibrillation. They can be combined with each other. One of them can lead to the other. If you organize atrial flutter by 1C, you get atrial fibrillation special form with special precautions. If you get rid of atrial flutter, can change into atrial fibrillation. So it's a lifelong treatment. Although the rate of success with this isthmus-dependent atrial flutter is very, very encouraging, 95%. Now we can even complicate matters by going into atypical forms of atrial flutter, which are not isthmus-dependent. They can occur around a patch because of closure of an atrial septal defect. They can be located around a scar because of an atriotomy to repair mitral valve or to replace mitral or any other valves. And under these circumstances, you have to use electroanatomical mapping. And this electroanatomical mapping will show you the scar, which is present here in اللون البنفسجي ده, and they can tell you that it's going in counterclockwise or clockwise direction. But an important point, this is a difference in opinion. You might hear something different from Ahmad al-Damati. This doesn't prove atrial flutter unless you do an entrainment. An entrainment is a process by which we pace the atrial flutter, and then we get a concealed diffusion. That's no change in the atrial flutter. And then we measure the post-pacing interval. It should be similar exactly within 20 milliseconds of the atrial flutter cycle. I will leave this for Ahmad al-Damati to explain it in more detail. But my point is, it's important to know what's the end point of what these people are doing. It's not enough to get rid of the atrial flutter. You should get bidirectional irreversible block. It's not enough in the case that you look into the electroanatomical mapping and then you start to get rid of the scar. You should entrain this process, because this is the only method by which you can prove that we have an re-entrant cycle. Now, having said that, what the guidelines say about treatment? If you have an acute onset of atrial flutter, recent onset, most of the patients with paroxysmal atrial flutter, they are free of structural heart disease. In contradistinction for patients with chronic atrial flutter, the majority of them, they have an underlying cardiac disease. So if you have an acute cardiac flutter, you decide, like in atrial fibrillation, you are opting for rhythm control because the patient is highly symptomatizing, or rate control if you can tolerate the atrial flutter. And if you choose the rhythm control, then cardioversion with a small amount of energy, like 50 or 70 joules, will be enough. Oral treatment with diflutalide or intravenous treatment by abutolide, unfortunately, this is not available. But the three considerations here are class 1 indication. If you opt for rate control, then if the patient doesn't have structural heart disease, you can use drugs like beta blockers, adeltiazem, and verapamil. If he is having structural heart disease, you avoid the non-dihydropyridine calcium antagonist, and you should be cautious but still eligible to use beta blockers. In presence of heart failure, the only drug you have here as a class 2A recommendation is amiodarone. Now, for chronic conditions, the situation is slightly different. If you choose the rhythm control, then the only class 1 indication is catheter ablation. It's easy for the typical isthmus-dependent atrial flutter. It achieves a 95% success rate, but always it has its own tails in terms of follow-up of the patient, with 30% atrial fibrillation and 3% or 5% recurrence. If the patient does not accept the atrial fibrillation, catheter ablation, then 2A is amiodarone, diflutalide, and sotalol. Unfortunately, we have no choice except to put the patients on amiodarone with its toxicity. If there is no structural heart disease, then it's easier. Propafenone is the only available to 1C, but flecainide is available approved. If you choose treatment by rate control only, so again, it's similar to the acute situation, beta blockers and adeltiazem. So based on that, I will stop at this stage, and I think we covered the use of SHATS-2 and SHATS-BASC score, warfarin versus DUAX, rate versus rhythm control, role of antiarrhythmic drugs, usually given first recommendation in patients with atrial fibrillation, and finally role of catheter ablation, which is the first line in atrial flutter, but a second line after trying antiarrhythmic therapy, at least for the examinations, as a second line. So thank you for your attention, and let's get some questions.
شكرا يا دكتور محمد.
لا. Do you have questions?
منتظر هو يشوف الأسئلة. الأسئلة بدأت تيجي.
أنا متوقع 6000 سؤال.
طيب. في أول سؤال when to restart.
No surprise. All of us are seeing atrial fibrillation on daily and hourly basis, and therefore I know that there are so many questions, but I wanted to make 2 points. Number one, this is a very important subject, no doubt. Well, this is a very dynamic subject. If you are interested to have a source that covers everything, it is the chapter or section في الواقع مش chapter, section of atrial fibrillation to the European Society of Cardiology textbook of cardiology. ده عبارة عن 114 صفحة answering everything. It's very important for those interested or serious about having all the questions answered in the proper way. This is the source. It's more complete than any guidelines. It's more complete than any chapter written in the book, and it includes atrial fibrillation, atrial flutter, and under specific situations like heart failure, chronic kidney disease, diabetes, coronary artery disease in association with surgery, all the recent things about ablation, description of the 12 types of occlusion devices that are available in the market, everything. and it has an introduction by a pioneer بعضكم يعرفوا اللي هو جون كام of King's College. فده is an extremely important source. You can't answer all the questions, of course. I know there are hundreds of questions في الموضوع ده هو, but don't invent يعني complex questions.
طيب هو السؤال الأولاني when to restart anticoagulation after cerebral hemorrhage in atrial fibrillation patient.
يعني ده سؤال, ما هو ده الأسئلة اللي هي practical. There is no guideline supported answer to this question. لكن what is the experts بيقولوا فيه ايه؟ You wait. أولا you have to have neurosurgeon with you عشان انك انت تقرر ده. انما you have to wait for some time. At this some time on the average 1 month. انك انت العيان اللي عنده cerebral hemorrhage that has been contained and he is becoming conscious, you have to wait for some time before anticoagulation. طبعا there is risk اذا كان hemorrhagic infarction. Usually العيانين بتوع atrial fibrillation he gets hemorrhage because of hemorrhagic infarction. He embolized. وبما انه بياخد anticoagulants, الهيموريدج ده هو البليدنج ده هو في قلب الانفاركت اريا. So if you stop the anticoagulants for a short time, the patient will protect him from embolization, but the hemorrhage is going to extend. So you have to wait for some time. So what people are advising us to do, انك انت you wait for almost 1 month, get the input of the neurosurgeon and make sure that you are doing safe anticoagulation. So even after 1 month, we anticoagulate the patients with heparin. Heparin is not a drug to antagonize the thromboembolism of atrial fibrillation, but just to make sure that heparinizing the patient is not going to increase the bleeding which is present. Well, now once you are assured من الحكاية دي, then you can implement direct oral anticoagulants, which are all of them having less intracranial hemorrhage occurrence than in patients on warfarin. So this is my answer. You might get different answers, but this is what I gather from the available literature.
طيب في سؤال تاني حضرتك بيقول anticoagulation for patients with atrial fibrillation and active cancer, warfarin or DOAC.
هو السؤال هل هو low molecular weight heparin or DOAC. الكلاسيك هو low molecular weight heparin, particularly when cancer is active. يعني the patient is not getting chemotherapy or radiotherapy. He had successful surgery if surgery is indicated, and there is no evidence of metastasis or lymph node metastasis. This is the definition of active cancer. So low molecular weight heparin. Lately this changed. ان هو DOAC can replace the low molecular weight heparin. The new edition of Comer and Clark came few days ago. I recommended very much للناس اللي هم بيقروا general medicine. And I looked specifically للchapter بتاع الأونكولوجي على this point. She is still writing. هي طبعا اتغير المؤلف واحد اسمه, هي اتشالت من الديريتوريال بورد او اعتكفت, انها كتبت برضه low molecular weight heparin. So it seems that low molecular weight heparin has not been removed from the choices. So based on that, I think in the low molecular weight heparin and the DOAC are the two competitors, but not warfarin. ده بالنسبة للعيانين اللي عندهم active cancer. After 6 months, if the cancer is not active, then the occurrence of thromboembolism will be minimal and you can stop anticoagulation.
طيب mechanism of vagal atrial fibrillation versus adrenergic atrial fibrillation.
اوكي, يعني طبعا I hope ان كان في سبوره وتخت عشان كده. في معادله very important. المعادله دي بتقول ايه؟ لامدا, اللي هو لامدا دي زي الواي المقلوبه. لامدا دي عباره عن الويف لينث. الويف لينث هي ايه؟ الدايره الكهربيه. الدايره الكهربيه تساوي ايه؟ تساوي الافكتيف ريفراكتوري بيريود. وانا اسيب لاحمد الضماطي يقول الفرق بين الابسولوت ريفراكتوري بيريود والفانكشنال ريفراكتوري بيريود والافكتيف ريفراكتوري بيريود. بس قبل ما احمد ضماطي يشرح دي، دول شرحهم في الالكتروفيسيولوجي ما لهمش دعوه بالسيل فيسيولوجي خالص اللي انت درسته في سنه ثانيه، وبالتالي شيل امسح من مخك خالص اللي درسته في سنه ثانيه اللي ريليتد للسيل. دي ريليتد لو حطيت امبلس قبل الاي في نود مثلا او اي تيشو، هي امتى ما تبقاش كوندكتد؟ هي امتى تبقى كوندكتد ببرولونجد مسافه بين الستيمولس والبيزال بيت، وايه الشورتست انترفال بعد ما تبقى كوندكتد. هنتكلم على احنا بنختار منهم ايه؟ فانكشنال ريفراكتوري بيريود مضروبه في الفيلوسيتي بتاع السيركل، يعني لامدا تساوي في اللي هي الفيلوسيتي في الفانكشنال ريفراكتوري بيريود. وبالتالي لو انت عاوز تصغر حجم الالكتريكال ويف لينث، عاوز تصغره ليه؟ عشان يبقى 5 6 7 8 تقدر تبقى اكوموديتد في الليفت اتري. لازم تصغره، يا تكبر الليفت اتري يا تعمل الاثنين. طب اصغرهم ازاي؟ اصغرهم بان اصغر ذراعي المعاديه، يقلل الفيلوسيتي فيجال ستيميليشن، يقلل الفانكشنال ريفراكتوري بيريود سيمباثيك ستيميليشن، وبالتالي الاثنين بيؤدوا الى شورتر ويف لينث اللي هي طول الدائره الكهربائيه. ريمبر ده لان انا هعقد الموضوع بعد ثانيه واحده شويه. تمام؟ اذا انا قللت الويف لينث قدرت اخلي 5 منهم الى 8 يبقوا موجودين في قلب الليفت اتري. خلاص دي نقلب الصفحه. في حاجه بقى اسمها باث لينث. ايه الباث لينث؟ الاناتوميكال سيركل. ما هي الويف لينث دي هتلف فين؟ حته اناتوم. الاناتوميكال سيركل لازم تكون اكتر من الويف لينث. يعني ايه؟ يعني الويف لينث الدائره الكهربائيه دي هتلف في حته، ما تقدرش تلف وتكمل الا لو هي بتلف في دايره، الدايره طولها اطول من الويف لينث. الفرق بينهم ايه؟ الاكسيتاتوري جاب. الاكسيتاتوري جاب زي الحته اللي انا شاورت عليها فيها السلو كوندكشن. لازم الهيد بتاع الويف ما تخبطش في التيل بتاع الويف اللي قبلها والا تكستنجوش ويقع. لازم يبقى في اكسيتاتوري جاب. جاء واحد اسمه اليسي وقال لا احنا ممكن نعمل حاجه تحقق بتاعتها بس تمشي في الريلاتيف ريفراكتوري بيريود بتاعتها. دي ثيوري للاتريال فايبريليشن انا مش عاوز اخش فيها لانها ادمت واتشالت، واتسمت ان دي نظريه انك انت ان يبقى عندك اكسيتاتوري جاب ملوش لازمه، ممكن ان هو تتم الاتريال فايبريليشن والويفز. لكن التراديشنال سيتنج والصح هو ما ياتي، هو ان انا عندي ويف لينث تساوي الفانكشنال احيانا بتتكتب افكتيف رونج. فانكشنال ريفراكتوري بيريود مطلوبه في الفيلوسيتي، فيجال يقلل الفيلوسيتي، سيمباثيك يقلل الفانكشنال ريفراكتوري بيريود. اي واحده منهم هتؤدي الى سمولر ويف لينث. سمولر ويف لينث معناها ممكن اكوموديت لارجر نمبر باتريال فايبريليشن. الويف لينث should be shorter than the path length. The difference is the excitatory gap. This is academic electrophysiology, but I think it's important لأي واحد interested في الموضوع جاي منين. لكن not important في التريتمنت ولا الميديكال مانجمنت ولا الافري داي براكتس. غيره. ياسر.
دي واحده بعدين حاجه حضرتك. بص يا دكتور محمد، في سؤال بيقول is there an absolute contraindication for antithrombotics that we do left atrial appendage occlusion without giving antithrombotics afterwards؟ يعني عايز يركب كده
السؤال خلاص انا فهمت السؤال. كل في 12 left atrial occlusion devices. الهدف من ليه كتروا كده؟ not because الواتشمان ديفايس ولا اللاريات ديفايس ولا البلاتسر اوكلوسيف ديفايس ولا الاميوليت ديفايس ديفكتيف. عشان النقطه اللي انت بتسيرها دي، هل ممكن اركب ديفايس ما نديش انتي كواجلانتس؟ هو دي الهدف كله. ده اندر ترايل. so far there is nothing like that. اللي موجود دلوقتي هو الواتشمان ابروفد، والواتشمان في الترايل كان بياخد انتي كواجلانس 45 يوم، وبعد كده بياخد ديوال انتي بليتلت ثيرابي لمده 6 اشهر، وبعد كده بيمشي على السنجل انتي بليتلت ثيرابي يوجوالي اسبرين. لكن الفكره نفسها طبعا، امال احنا عاوزين، احنا عندنا واحد بنقول هو ما يقدرش يستحمل لونج تيرم انتي كواجلانس. على خد بالك الجايد لاينز مكتوبه بطريقه حرفيه كتيره جدا، ما كتبتش كلمه لونج تيرم. لونج تيرم دي من عندي، كتبت ان هو there is a reasonable excuse ان ما ياخدش انتي كواجلانس. reasonable excuse او حاجه زي كده معناها ايه؟ انه كان بياخد انتي كواجلانس جاله هيموريدج، او كان بياخد انتي كواجلانس وجاله ثرومبو امبوليزم، فعنده سبب انه ما ياخدش انتي كواجلانس، لكن ما عندوش كونترا انديكيشن انه ياخد انتي كواجلانس. لكن طبعا if you stretch your imagination you like to have an occlusion device and you stop anticoagulants. That's what people are working upon. وهذا السبب ان هو ليه طلع اكثر من واحد من الليفت اتريال occlusion devices.
هو في سؤال برضك واضح ان السؤال بتاع الفيجال اي اف والادرينوجين جاي فيه تاني. هو اعتقد السؤال هو ليه في بعض الناس بيبقى عندهم فيجال وبعض الناس تانيين عندهم ادرينوجين، لو انا فاهم السؤال صح يعني.
اوكي، ليه ناس عندهم فيجل وليه ناس عندهم، في ناس عندهم الهارت ريت بتاعهم 75، ناس عندهم الهارت ريت بتاعهم 60، وناس عندهم الريستنج هارت ريت بتاعهم 80. انك انت عندك ذراعي الاوتونوميك نيرفس سيستم بيشتغل في بعض الناس ما بيشتغلش. لكن في نقطه مهمه ان في سترونج ايفيدنس ان فيجل اتريال فايبريليشن از فاميليال اند جينيتيكالي ديترميند. هل ده ينطبق على الادرينرجيك اتريال فايبريليشن؟ maybe we are very short of complete knowledge about the genetic mechanism underlying atrial fibrillation. It's a nice thing to read about. لكن زي بتقرا مثلا على stem cell transplantation nice ideas، لكن على ارض الواقع لم تحقق شيء. فهو برضه نفس الحكايه، الجينيتكس بتاع الاتريال فايبريليشن هي abnormality في انهي channel، هي الابنورماليتي دي بتبقى ترانسفورمد ازاي الى فينوتايب ما نعرفش. لكن there is strong evidence ان العيانين اللي بيجي لهم atrial fibrillation بعد الاكل، او اللي بيجي لهم atrial fibrillation بالليل when the vagus nerve stimulation becomes evident انه they have a familial pattern، واخد بالك؟ فده ممكن يكون سبب.
طيب سؤال تاني بقى عن حالة حضرتك، فيميل 75 سنة hypertensive وعندها
انا حكايه الحالات احنا اتفقنا الحالات دي بناخد incomplete information، بس قولها برضه يعني، لكن بلاش حكايه الحالات، اسال اسئله عامه.
طيب
انما قول الحاله، لان بتبقى incomplete information.
خلاص مش مشكله. السؤال ده حضرتك البيشنتس اللي عندهم ليفر سيل فيلير هنعمل ايه في الانتي كواجوليشن في الاتريال فايبريليشن؟
دي سهله اجابه السؤال ده. We no longer direct oral anticoagulants كلهم renally excreted, they are metabolized in the liver and this is of minimal importance. لكن هو البروبلم ان هم renally excreted.
لا هو اعتقد يقصد على السبونتينيوس انتي كواجوليشن بتاع الليفر سيل فيلير، يعني ندي معاه انتي كواجوليشن ولا يعني واحد مثلا 3.5 4.
شوف اقول لك حاجه، خلينا براكتيكال. لما بيكون عندي عيان عنده اند ستيج رينال فيلر جوندس وعنده هيباتيتور هيباتيكاس والفلاتين تريمور والاي ان ار بتاعه 7، this patient I don't opt for rhythm control. I treat the patient with the rate control and with the minimal interference. Obviously انك انت لو قلت ان العيانين دول هم الاي ان ار بتاعهم بقى اكتر من 2 اكتر من 3 then stop anticoagulants. لكن في الواقع الليترشر هنا هو فيها كلام جديد، او فيها مش كلام جديد، كلام مهم. ايه الكلام المهم؟ ان هنا في نوع من الاي ان ار بيتسمى اي ان ار سي، بيتعمل للعيانين اللي هم عندهم hepatocellular dysfunction and they are candidates for anticoagulation. ففي لابوراتوري تيست خاص بعيانين الليفر سيروزس اللي هم عندهم الاي ان ار بتاعهم عالي. ليه؟ لان الاستاديز ورت ان كثير من العيانين اللي عندهم الاي ان ار عالي العيانين دول هم they get thromboembolism. remember انه البروبلم في بتاع الليفر in relation to anticoagulation انها مش بس بتعمل bleeding، هي بتعمل بليدنج لان الكواجوليشن فاكتورز كلهم ما عدا فاكتور 13 بيكونوا في الليفر. لكن كمان هي بتعمل ثرومبوزس لان الفايبرين والليتيك ايجنتس كمان بيكونوا في الليفر، اذا ما تكونوش هيحمل ثرومبوزس. وبعدين بتعمل disseminated intravascular coagulation. So these are the three coagulopathies related to the liver. وعشان كده الاي ان ار is not reliable انك انت تمنع الانتي كواجوليشن. لكن انت خلينا في سيتويشن عيان عنده end stage renal failure hepatic failure وهو الاي ان ار بتاعته عاليه وهو الشادز فاسك سكور بتاعه معديه، ما انت لازم اللي يحدد لي شادز فاسك سكور ممكن ما يكونش معديه يبقى واقف. يبقى اذا في الحاله دي هي انت عاوز تدي العيان ده وارفرين هتعمل له اي ان ار بالنوع اللي انا قلت عليه اللي خاص بالليفر سيروزس. On the assumption of several studies in the past which showed INR is not a guarantee in spontaneous anticoagulation will prevent the cardioembolic phenomena بتاع الاتريال فايبريشن. هذا الكلام بقى قديم انما موجود. انا ممكن اديك الريفرنس لو اديتني دقيقه ورايا في المكتبه هنا هو الريفرنس. لكن الكلام ان هو ليه بقى قديم؟ بعد ما طلع الدواء we can anticoagulate the patient بريفاروكسيبان او بإليكويس، هم دول اللي افيلابل ليه. وتراي ان احنا انتيكواجوليت بإليكويس لان واضح ان الإليكويس سوبيريور. ريمبر الاثنين التانيين نون انفيريور. نمره اثنين you can use them in a renal degree of renal dysfunction زي ما اتكلمنا حديثا. نمره ثلاثه انه بيتعايز twice daily so you get a problem it's relatively short half life although all of them حوالي 12 ساعه. لكن الجايد لاينز الترايلز ورا تديله مرتين فهو on the lower side of this. ده الموضوع اللي انا عاوزه.
السؤال اللي بعديه عن الفوندوبارينوكس as an anticoagulant in hospitalized patients with atrial fibrillation.
No role. Fondaparinux is a heparin. We don't anticoagulate atrial fibrillation. No role. على فكره فوندابارينوكس ده لو قلت في امريكا فوندابارينوكس هم ما يعرفوش انت بتتكلم على ايه. اريكسترا ده انا مش عارف ايه الغرام اللي موجود في مصر بالاريكسترا. الاريكسترا ده very rarely used وهو عباره عن very low molecular weight heparin ونورال فور هيبرين. الجايد لاينز بتقول العيانين اللي عندهم كارديو فيرشن وعندهم اتريال فايبريشن less than 24 دي شوت اوف هيبرين اند كارديوفيرت. طبعا كل الجايد لاينز مصممه على شوت اوف هيبرين 5000 وحده انترافينوسلي اند كارديوفيرت. لوجيكالي انا ما بعرفش الشوت اوف هيبرين ده هيعمل ايه انما اتس اوكي يو ار ان ا ثرومبوتيك ميلييه اند يو جيف ذا بيشنت هيبرين. apart from that مفيش رول اوف هيبرين الا في البريجنسي لانك انت مضطر ما تديش وارفرين وما تعرفش اذا كان الدواء تيراتوجينيك ولا مش تيراتوجينيك فانت فورسد انك تدي هيبرين في الفيرست ترايمستر وفي اخر 15 يوم او اخر اسبوعين وبس مفيش رول اوف هيبرين. اوكي. طبعا ده بيجاتران ما بيتعطاش الاول بيتعطى اندر باك جراوند اوف هيبرين زي الوارفرين لكن ريفاروكسابان ايبكسابان اندوكسابان بيتريكسابان كل دول هم بيتعاطوا من غير هيبرين.
طيب هنا بقى سؤال على الدوز بتاع الابيكسابان في البيشنتس على الهيموداياليسيس. هندي فول دوز
2.5 ملغ twice daily. Always you have to check. شوف don't ask me about the doses. check it. كل مره بندي الدراج ده بنشيك يعني دلوقتي اغلب الممرضات في المستشفيات في فارماسيست بنخلي الفارماسيست ده يتشيك الدوز. مفيش حاجه اغلب الامتحانات انا اي دونت ثينك في المالتيبل تشويس كويشن في اي سؤال عن الدوزز حتى الدوزز بتاع الامرجنسي دراجز MRCP نو كويشنز اباوت ذا دوزز تو تشيك. مين اللي قال ان احنا نضيع وقتنا بان احنا نحفظ الدوزز؟ والله اذا كنت حافظها واثق منها ده هايل لكن لو كنتش حافظها تشيك. انما دي ات هابنز ان ده الدوز انا حافظها ان هي 2.5 ملغ despite that انا بتشيك. اولا ممكن تتشيك على التليفون وده طبعا ليس ريلايبل انك تتشيك على البي ان اف او على الامريكان PDR. انفورشنتلي ده مش موجود في المستشفيات بتاعتنا ما اعرفش ليه لكن ده اكستريم ديفيشنسي بره كل نيرس ستيشن عليها الفارماكوبيا ده. هو من المفارقات ان من 100 سنه كان في حاجه اسمها الايجيبشن فارماكوبيا، كان بيكلمنا عنها الدكتور عبد العزيز شريف. اي نيفر سو ات، لكن كانت وزاره الصحه بتطلع فارماكوبيا فيها الافيلابل دراجز وريكومندد دوزز، وبتتوزع بالمجاني على المستشفيات. نو لونجر شود بي.
اوكي تمام كده يا دكتور محمد.
خلاص كده؟
كده الاسئله.
شكرا جزيلا وتصبحوا على خير.
تصبحوا.
شكرا يا دكتور محمد وتسلم ايديك.